This video continues Chapter 23 of OEC6, looking at chest trauma, and we continue with chest injuries, specifically some very critical traumatic injuries, including pneumothoraxes, hemothoraxes, pericardial tamponade, and stoppage of the heart due to commotio cordis. So these common chest injuries can take the form of several cases. In the case of a pneumothorax, we may have both open or closed, but essentially what we have is a leak in the lung allowing air to collect between the lung and the pleura, which is the sac surrounding the lung, and so consequently we get pneumothorax, air in the thoracic cage. Now, if we collapse the lung as you see here due to the pneumothorax, you can imagine that the patient will experience shortness of breath and hypoxia because the lung cannot fully expand and will end up with poor air exchange and poor perfusion. As we said before, it could be caused by either blunt trauma, a closed pneumothorax, or penetrating trauma leading to an open pneumothorax. Additionally, compressive forces on the chest can lead to this. In an open pneumothorax, a sucking chest wound, we have an opening in the chest wall and outside atmospheric air enters the chest cavity and finds its way into that pleural space. Therefore, every time the patient inhales, the difference in the pressure between the thorax and the atmosphere causes more air to be sucked in, and eventually the lung will partially or totally collapse. Again, what will this lead to? Decreased gas exchange and hypoxia. We see that animated here, the opening in the chest wall due to penetrating trauma and the entrance of atmospheric air into the space. Now, right here at the opening in the chest wall, we may hear a sucking noise each time the patient breathes. Rather than air following the pathway as it should, the decreased pressure in the thorax is allowing air to enter through the hole. It becomes a sucking chest wound. Now, in the case of blunt trauma, we can also lead to a pneumothorax. If you have a direct blow covering a large area of the thoracic wall, you can have a break in the lungs, bursting in the lungs, and that will allow air to accumulate in the pleura. If the air continues to accumulate, we end up with a tension pneumothorax. That is pressurized air, the tension piece in the pleural space compressing the lungs. There's no way for the air outside the lung in this space to exit because it's closed, and if left untreated, we're going to actually get displacement of the mediastinum. We're going to cause the organs in the chest to become compressed, and again, reduced lung capacity. With enough pressure, one lung will completely collapse, and we see, in addition to the displacement of some of the organs in the mediastinum, collapsing of the vena cava. What will this result in? Well, this will result in some key signs and symptoms that we'll take a look at in the next slide. But additionally, closed chest trauma could allow for a sharp bone fragment of a fractured rib to puncture a lung, and it is from that opening in the lung, not an opening in the exterior chest wall, but an opening in the lung, that air again gets into the pleural space, and that pressure can build up, creating the same life-threatening situation. We can make it worse if we use a BVM to actually increase the pressure of air coming into the lung, because again, if we have that leak and that high positive pressure allows for air to build up outside, will collapse the lung even further. Be sure, using a BVM for rescue breaths, or in the case of CPR, to not overinflate the lungs. Now, in any case, the signs and symptoms will be shortness of breath and that hypoxia. And we can see distended neck veins because of the displacement of the mediastinum and displacement of the vena cava. So we get blood backing up and it becomes visible in the neck at the jugular vein. They become distended and visible. decreased lung sounds if you're able to listen with a stethoscope, and further, tracheal deviation, that is, the trachea will push away to the other side, again because of displacement of the mediastinum. A very funky symptom that can be observed, or rather a sign, is subcutaneous emphysema. We'll just say sub-Q air. What happens is air becomes trapped under the skin in the subcutaneous layer, and it results in a crackling sensation when you palpate the area. That subcutaneous emphysema will be found at the highest point of the chest cavity. It's usually benign, but the underlying cause, the pneumothorax, is life-threatening. Sometimes the pneumothorax can occur spontaneously, typically in young adults, because a small defect in the lung surface ruptures, and the signs and symptoms will be the same, in particular that sharp pain in the chest that radiates to the back. Hemothoraxes are similar. We just changed the prefix because we changed the cause. Instead of air in the pleural space, blood accumulates with the pleural space. And again, that can be due to just rupture of the small blood vessels inside the chest due to blunt or penetrating trauma. In the case of hemothorax due to arterial bleeding, that will rapidly progress and can be potentially deadly due to hypovolemic shock. The pleural space can hold 3 to 4 liters of blood. Think about the capacity of your lungs and transfer that to just the amount of fluid that could be in that space as well. That will collapse one or both lungs, leading to hypoxia and shock. And additionally, if air is leaking as well, we can just combine these two ideas into a hemo-pneumothorax. Air and blood both in the pleural space, and that's typically associated with multi-system trauma, and these patients are very, very urgently transported to ALS. Now, the idea of a case or a sac around an organ is shown here as well. The pericardium is that encasement of the heart itself, pericardium around the heart, and if we get blood leaking into that space due to rupture of a cardiac blood vessel, we're going to end up with pressure on the heart because this pericardium is actually limited inside. It's not super flexible. And so fluid buildup inside will just compress the heart inside as well. It's occasionally caused by non-traumatic medical conditions such as some sort of infection. We see that will constrict the heart from filling properly, and typically this occurs in the right ventricle first because the left ventricle has a thicker muscular wall. And what happens is, consider that the venous return of blood coming from the body enters the right atrium and then the right ventricle before heading out the pulmonary artery to the lungs. That backup on the right side of the heart will again show up as jugular vein distension. Cardiogenic shock, that is stoppage of the pump, the heart, can happen pretty quickly. The early signs, pain and shortness of breath, that jugular vein distension, and if you're able to with the stethoscope to listen, you'll hear muffled heart sounds. A couple of other things will show up too if you have a BP cuff. You'll get a decrease in the pulse pressure, which is the difference between systolic and diastolic blood pressure, and also pulsus paradoxus. Normally, when you breathe in, the reduced pressure in the chest causes the top number in your blood pressure, your systolic pressure, to drop a little bit. Pulsus paradoxus is a drop when you're breathing of greater than about 10 millimeters of mercury. Now that's kind of a high level assessment tool that we have, but it can assess for pericardial tamponade with something like greater than 98% sensitivity. Another chest injury that's possible, particularly in young people, is commotio cordis. A direct blow to the chest will interrupt the electrical activity and cause VTAC or VFib. This often happens if you get a direct strike to the front part of the chest, such as a baseball or a lacrosse ball, or perhaps contact while skiing. 90% of the cases will be in children less than 16 years of age. That disruption of the heart rhythm, moving to VTAC or VFib, is going to be treated. We'll go down our CPR algorithm. Traumatic asphyxia is where external pressure on the chest wall just doesn't allow you to breathe. We just have that crushing and compression, and it can result in hypoxia or anoxia, a complete lack of oxygen because of the compression not allowing you to breathe. Now, that compression could be by entrapment in avalanche debris, and understanding that how concretely the snow will pack around the victim as the air comes out of the snow following an avalanche. And also, it can result from thoracic cage fractures that simply don't allow the chest wall to expand. For any one of these chest injuries, high altitude can complicate what we're seeing just because at high altitudes there's a lower partial pressure of oxygen. It's still 21% of the atmosphere as a fraction, but the external pressure, the barometric pressure, is less, and so the fraction of oxygen, its partial pressure, is less as well. That can cause any of these cases to worsen, and so one thing to consider is to take that patient with a chest injury to lower elevations, and that could be by calling in a helicopter for evacuation.